So, as Alok already summarized as well, so what is diabetic ketoacidosis is in fact an emergency condition, so which is really characterized by, in fact, uh, hyperglycemia, dehydration. In fact, whenever you will look at the metabolic parameters as well, there will be derangements in such parameters, and in fact, you will be able to even notice acetone, in fact, as well. And a lot of times, the people or our colleagues, friends, they tend to think that, oh, it's only associated with type 2 only. Nope, not at all. In fact, it can also be seen also in type 1 as well. And in fact, um, one fourth of the type 1 diabetic patients present to a hospital setup, in fact, with this problem, in fact. So now coming to the definition, as we already said it has a mix of the triad of acidosis, ketosis, and hyperglycemia. So that's why diabetic, and keto and acidosis. Okay. So now what about the pathogenesis? So we all are aware that a diabetic patient who is having the insulin deficiency, so there are several problems which are associated with them, like the beta cell failure, okay, and even there's problem also with the insulin as well, and there is associated glucotoxicity, in fact. So in our body, what happens is there has to be a harmony or balance between the insulin deficiency and simultaneously on the other side of increased glucagon, GH, cortisol, and catecholamines as well. And whenever this balance is deranged, problems happens. Problem happens in the sense if there is absolute insulin deficiency. So then what is going to happen is this is definitely going to increase the liver. In the sense, it is going to stimulate it for increased glucose output. So hyperglycemia is going to be there. In fact, similarly, increased glycogenolysis is going to be there. And what is going to happen is on the muscle, the effect is going to be there is decreased glucose uptake, due to which there is more and more gluconeogenesis leading to increased higher glucose, and there's more protein breakdown from that side on the muscles, which leads to increased amino acids and lactate, in fact. And on the other side as well, due to higher lipolysis, there's increased level of the glycerol, leading to further gluconeogenesis, in fact. And these are mediated by the gluconeogenic enzymes, in fact. So this is the reason which leads to ketogenesis, okay, due to the more and more amount of lipolysis, in fact. So what happens is that is the reason, as I said it, there is a key role of liver, the peripheral tissue, and also the adipose tissue for the pathogenesis. In the sense, as I already said it, the liver is the one which leads to increased glucose production, okay? And similarly, peripheral tissue is the one which is going to cause the decreased glucose uptake. So both of them combined together leads to hyperglycemia, which further leads to the osmotic diuresis, leading to volume depletion, in fact. So, and then on the other side, as I said it, adipose tissue, by increasing the release of free fatty acids. Similarly, on the liver, on the other side, as I had said it, increased ketogenesis is happening. So, combined together, keto and acidosis as well, which tends to decreased alkali reserve. And this is the reason which is going to lead overall to metabolic acidosis. Okay? So now are you confident about the pathogenesis? So what is the diagnostic criteria for this disease, in fact? So you can further classify into mild, moderate, and severe as well. So as you can notice over here, if so for example, the plasma glucose is going to be more than 250 milligram per deciliter for in all the three conditions. Similarly, the pH is one of the key things. Key things in the sense, so if the pH is less than 7, severe, 7 to 7.24, it is moderate, and 7.25 to 7.3 is the one which will be mild. Then the other thing which you have to look out for is anion gap. I hope you all can recall about my ABG session, which we spoke about how to calculate the anion gap as well. So if it is more than 10, mild, and if it is going to be more than 12, moderate, or even for severe as well. Similarly, the other important thing which tends to really differentiate our diagnosis for mild, moderate, or severe is the bicarbonate, milliequivalents per liter. So, for example, if it is less than 10, severe for sure. Then 10 to 15 is moderate. And if it is between 15 to 18, okay, mild, okay. Similarly, if you're going to be seeing for urine ketones or serum ketones as well, of course, this is going to be positive. And when you're trying to see for the effective serum osmol, the levels can be variable. Of course, one of the key important things is about seeing for the clinical features. Clinical features, what you try to look out for is the alteration in sensoria or mental obtundation, in fact. So, what is of course going to happen is if someone is having a mild DKA, the person will be pretty much alert. They will be able to obey or listen to you, respond as well, very well. In fact, however, if it is going to be moderate, they may be alert, they may be drowsy as well. But of course, if someone is having a severe, they will be stupor or in coma. So, as clinicians, or as for a patient as well, they are very much aware like, what about the symptoms? What are the problems they are going to have? So, they will be having something like polydipsia. So, polydipsia, what does it mean? A lot of thirst, okay? Polyuria, increase urination frequency. Similarly, weakness is going to be there. They are going to be telling, I'm not feeling good, I'm feeling weak, I'm not able to do my regular activities. They will also be having history of weight loss, similarly associated with nausea, vomiting, or even abdominal pain as well. Now, coming to the signs. Signs are the things, those clinical features which we are able to elicit, like the physicians, in fact, or even our nursing colleagues as well. So they are hypothermia, tachycardia. So tachycardia and tachypnea is more like a reflex mechanism which is happening in those patients which we come across. And Kussmaul's breathing. Kussmaul's breathing, would anyone like to explain? So what is Kussmaul's breathing?
Short and deep breathing.
What did I say? Please use the chat box. I would really appreciate that. I hope you guys are listening to me. Please use the chat box. So, because it becomes easier for everyone to be able to understand as well what one is telling. So, please use the chat box. See, one thing, key thing I would say, don't confuse Kussmaul's breathing with Kussmaul's sign. So, now it takes me to another clinical question. What is Kussmaul's sign? I know I'm a little bit diverting from the topic, but being clinicians, you should be able to know as well. So what is happening is Kussmaul's sign is a paradoxical rise in the JVP on inspiration. So it is a paradox. So normal thing what happens is it's opposite, okay? So that's why it is called as a paradox. So what happens is normally on inspiration, what is going to happen is there will be a down, but over here, due to the paradox, the JVP rises, or there is failure in appropriate fall of JVP with inspiration. So that is the key thing for the Kussmaul sign, and it is associated, of course, in some of the forms of like heart disease, okay, and normally it is due to the limited RV filling due to the right heart dysfunction. Now coming to the Kussmaul's breathing. So, as one of our smart colleagues already said it, so it's a deep and labored breathing pattern which is mostly associated with the severe DKA. Okay, and so what are the other conditions? Can anyone tell me where you can see the Kussmaul's breathing? So it can also be seen in cases of kidney failure. Yeah. So it is more of a, I would say, like a hyperventilation, which is any breathing pattern that reduces the carbon dioxide in the blood due to increased rate of depth of respiration. Okay. And as I was telling you, so what happens is in metabolic acidosis, actually, the breathing is first rapid and shallow. But as the acidosis worsens, the defensive mechanism of the body tends to kick in. And that is where what is going to happen is the acidosis is going to worsen, the breathing gradually becomes deeper, labored, and the patient will be having gasping episodes as well. And in fact, this is the later type of breathing pattern which is referred to the Kussmaul's breathing. So, deeper breathing, labored breathing, and with associated with gasping, which is, as I already said, it is associated mostly with the diabetic ketoacidosis, but also with the kidney failure as well. In fact, this was named after Adolf Kussmaul, in fact, who is the one who had presented this wonderful term, in fact. Okay? So, what about the other clinical signs which we all can see? It is called as the acetone breath, or even the altered sensorium, which I've already said it. And I must say, when you talk about its onset, it can be relatively very short. So, like maybe just a few hours as well, and even ranging from hours to a day or two as well. So, it can be pretty varying, in fact. So, when you think about the causes, as I was already telling about the diabetic ketoacidosis, so diabetic ketoacidosis can also be due to the various precipitating factors. What are those factors which are associated? So something which is like a body stress in terms of like a infection, like a upper respiratory tract infection, or the pneumonia, or even if someone is having a history of alcohol intake, or any history of stroke, myocardial infarction, pancreatitis, trauma, medications, or even someone is not taking any insulin as well. So when we try to ask, so one of the key things, whenever such kind of patients they do come to us, one of the key things is we should try to always never forget your basics. Basics is A, B, C: airway, breathing, circulation. In fact, and always try to assess for the mental status of the patient. And then on the other side, one of the things which you should try to see for is the cardiovascular renal status. How is it? What about the possible sources of infection? Then, then after that, you must be able to evaluate the volume and how about the hydration status. So, for example, if the patient is euvolemic or dehydrated, how much dehydration is there as well? And in the meantime, of course, try to get the lab tests done. Lab tests done, what I mean is, try to immediately seek for the random blood sugar from the fingers immediately over there, and also 3-BH serum ketone levels as well, immediately by the finger stick or urine ketones. And I'm going to give you a short summary as well in the end, in fact. So, about the lab studies, what important is the ABG. Can one tell why ABG? Because to tell you what happens is we are also interested in knowing the serum electrolyte levels. How about those the kidney function, as I've already said it as well? Then because we are also curious to know about its differential diagnosis. Similarly, what about the complete blood count about with the differential leukocyte count as well? Then in the meantime, try to have a look for the glucose, the electrolytes, bicarbonate, BUN, creatinine, and I had already stressed quite a lot about the serum ketones, the urine analysis. You should try to get it done and see for the bacterial culture as well. As I said it, because you will be able to know about the precipitating factor which is associated for that, and how about the cardiac enzymes which is there for this disease. So one of the key electrolyte problems, which is associated in the hyponatremia, is in DK is hyponatremia. Okay, and this is happening is due to the osmotic diuresis, in fact. So when you're trying to think how much should be the corrected sodium, so this is a wonderful formula which I had already said even in the ABG session as well. So if you're thinking that you want to correct the sodium, so this is a very important formula which it should be there in everyone's mind, in fact. And what happens is whenever on the other side, if you're trying to see for the serum potassium levels as well, the serum potassium levels are going to be pretty much elevated because of the shift of potassium from the intracellular to the extracellular space. Okay? Because as we all are aware, so what happens is insulin is the one which regulates the activity of the sodium potassium pump, which is altering for the sodium and potassium levels, in fact. So we had already spoken earlier as well about the anion gap formula. Anion gap is serum sodium levels minus the bicarb plus the chloride, in fact. So as I already said, most of the times these patients are definitely dehydrated. So fluid therapy is one of the really fundamental important things which should be taken care of for such patients. So what happens in this is you have to see for the normal saline. So normal saline, 1 to 2 liter is at least given over a period of 1 to 2 hours itself. Otherwise, if you're giving is half normal saline as well, you can give it at the rate of like 250 to 500 ml per hour. And again, if the glucose levels are low less than, I mean, is 250, then I would really suggest is you can give 25% dextrose as well. Okay? So I hope I'm able to get it clear. So are there any questions so far? Okay. So now what about those important precautions one should be taking during the fluid management? As I was telling you, so one of the important things for us is you should be able to replace the fluid over a time of like 12 to 24 hours. Yeah. And then what happens is, as I had already said it, those patients who are here, they are really, really severely depleted, in fact. And what happens? Hello? Yeah.
Dr. Narendra. Hello, Dr.
Yeah.
Narendra. Doctor, could you please go back to the previous slide because the connectivity got lost? Yeah.
Okay.
You can start from the slide, doctor. So sorry for it. There was some connectivity problem.
Okay. Never mind. So as I was telling you, so you have to try to see for the there is a dehydration in the patient. So that's the reason you are trying to do is give normal saline. Normally you can give 1 to 2 liters over 1 to 2 hours. If there is hypoglycemia, not hypoglycemia, I would say, like if the glucose levels are less than 250 milligram per deciliter, you can give dextrose 5% as well. So one of the key things which is important to be kept in mind whenever you're trying to treat such patients, you should keep it in mind is that these patients are mostly dehydrated. So you must be able to at least give them good amount of fluid, at least 3 to 6 hours, in fact. Okay. And then one of the other important things is, yes, whenever these patients are coming to you with congestive cardiac failure and kidney disease as well, we have to take care of those associated heart failure or these problems as well. Because as I said, these problems can be associated and they can really clinically worsen the patient, in fact. Yeah. So similarly, being diabetic patients, we have to keep on checking for those blood glucose levels as well. Or I would say like initially on an like every hourly basis. And the goal is to decrease the glucose levels at least at the rate of 50 to 75 deciliter per hour, in fact. And once you have taken 3 measurements, and there's a good level, you have been able to receive a target level, or it is one stable, in fact, okay, you can change the monitoring levels to every 2 hours, in fact. And then after that, you can also further change the insulin infusion rate as well, and that is the time when you can add dextrose 5% IV fluid when the glucose levels is going to be less than 250 mg per deciliter. So as I was telling you about the goal, especially the glucose levels, we should have a goal of like 150 to 200. I wouldn't say it like too less, too more. So 150 to 200 is a good level, and in the meantime, in the same time as well, I would suggest to uh, keep on monitoring the anion gap as well. So we hope at least by the time you reach those normal glucose levels, anion gap should also close. Okay. So as I was telling you, the IV bolus dosage of insulin therapy, it should be around zero point 0.1 unit per kg, and then after that you can even change to using the drip 1.1 unit per kg per hour, and once you are able to achieve good levels of glucose control, then you can decrease the dosage by half. Decrease the dosage by half, I mean, is you can go up to 0.05 per kg per hour till the anion gap is corrected. So when you are thinking about the changing the insulin infusion rate, so as I already said it, you have to decrease it by 50%, right? Isn't it? So even for the the on the other side as well, okay, random blood sugar levels as well, I said it, and per hour as well, as I said it, you should try to achieve at least is like 50 mg per deciliter per hour, in fact. Okay, and then the infusion rate, of course, has to come down by 50%. So till the time you are able to treat or resolve the ketoacidosis, you have to keep on treating with the IV insulin. There's no doubt about it. And how do you know that the DKA is resolved? So that is the time when you can think of switching over to subcutaneous insulin. So mind you, till that time, the patient is in stress, so you should not use any subcutaneous insulin at all. So how do you know the patient's danger time is over? Then you will be able to see the blood glucose levels is going to be less than 200. Bicarbs are going to be 18, which I had already said it. Similarly, the venous pH, when you're going to do is, it will be more than 7.3, and the anion gap will be closed. And so, as I said it, once you are knowing for that, that is the time you can start the subcutaneous insulin, and at twice the hourly IV rate. Okay, so for example, the IV rate was like 5 units per hour you were giving. So give subcutaneous insulin can be like 10 units, in fact. And why, again, we are trying to stress that there should be a change from the IV to the subcutaneous, because, again, such patients are very much prone for rebound hyperglycemia and even ketoacidosis as well. And you must ensure that the patient has a meal and also is awake as well. So about the potassium, we had already said it, if it is more than 5.5, nothing to be worried about. Okay, but yes, if potassium, we have to try to maintain slightly on the higher side. So that's why I said it. So if it is 4 to 5, so then give around 20 milliequivalents per liter of the replacement fluid. Similarly, you should double it if the potassium levels are 3 to 4 milliequivalents. Okay. Bicarb, as I had already said, if the pH is more than 7, no need for bicarb at all. But if pH is less than 7 and the bicarb is going to be less than 5 milliequivalents per liter, then you should give 44.6 milliequivalents in 500 ml. Okay, 0.45% saline over 1 hour till the time it becomes normal. Like any other medical condition as well, it can be associated with complications. So what are the complications? Sepsis, myocardial infarction, ARDS, the adult respiratory distress syndrome, thromboembolism. Although we see those thromboembolism episodes most commonly in elderly patients, Coming to the complications of treatment, it can be associated with hyperkalemia, which can further lead to cardiac arrhythmias, cardiac arrest, or even respiratory muscle weakness as well. And as I was telling as well, yes, hypoglycemia can be there. And in fact, when those patients are, if you're not monitoring the fluid levels well, you can make those patients land up in overhydration. And those patients can have um, clinical features even of acute pulmonary edema. So that's why, whenever, if someone is, you have already seen that someone is having a compromised renal or cardiac function, or especially kids if they are there, otherwise elderly people as well. So you have to be a little bit extra cautious that don't overhydrate them. Similarly, if there are neurological patients, you may see some neurological complications as well, like cerebral edema. And as I was telling you, you have to be very careful if you develop neurological complications, especially in those kids, because it can be associated with not just the duration, severity, and also the rapid correction of the diabetic ketoacidosis. So you should be careful, but don't make it too quick as well. The reason for this is due to the intracellular or idiogenic osmose, which is produced in the brain, is, and actually it is being produced is because the brain cells, they are trying to make themselves stable rather than preventing the shrinking. And when the DKA was developing, in fact, and that's why whenever you're trying to correct the hyperosmolality, the brain becomes hypertonic towards the extracellular fluids. And that's the reason the water is going to, of course, flow inside the cells, and there's going to be cellular edema. And to make an overall summary, what is happening is DKA is very common, very serious, and expensive complication in patients who are having type 1 or type 2 diabetes as well. And yes, prevention of the decompensation through patient education, strict surveillance of the glucose homeostasis, and also aggressive diabetes management might reduce the high morbidity and also the mortality which is associated. So, okay, so now we will try to go into the question mode. So, question mode means we'll try to discuss some practical situations as well. Are there any questions so far? Please feel free to use the chat box. Okay, I guess I have a very smart audience today. My students have become really, really good. That's real nice. Okay, so as we already said it, what about those things? What is DKA actually? It's a mix of hypoglycemia, DKA. D means hypoglycemia, K means ketosis is the A for acidosis is there, and of course associated with dehydration and electrolyte imbalance as well. So as I already said it about ketosis and acidosis, so what is happening is it is happening due to enhanced gluconeogenesis, okay? Because the body is thinking due to less insulin or no insulin, so body is thinking, oh, let's make more and more glucose because there's shortage of glucose in fact, and the glucose is coming from the gluconeogenesis. That's the process, okay? And how is it happening is due to the lipolysis. So the lipid cells and all, they are getting killed in fact, due to which what is happening is those free fatty acids are going to be there, and that is the one which is leading to ketosis. And what are those ketone bodies is acetoacetate and BH, beta hydroxybutyrate. Okay, and as I was telling you, ketone bodies are the one which dissociate into the ketone anions and the H plus and ketone anions. And yes, so initial few time, yes, the body will be using its buffering capacity, and later on it is going to become problematic, and you are going to see the evidence of dehydration in the sense of, and it is happening is due to osmotic diuresis and also vomiting. The patient will be having all these problems, and there will be associated electrolyte imbalance. Electrolyte imbalance, as we spoke about, is they will be having hyperkalemia, hyponatremia, even the phosphate depletion will be there, especially in most of these patients, in fact. And the main reason for this is osmotic diuresis, okay? And that is the one which is further affecting because of the lack of insulin. The final thing which is happening is affecting is the sodium potassium pump, in fact. So I will try to summarize the new model. So what is this new model? In this new model, they have tried to standardize the diagnosis about its treatment and what should be done, especially regarding the insulin, because there has been a lot of confusion going around what should be done, what not should be done, in fact, as well. So what happens is there is a big variability. So, for example, if there is a young adult, there is a old person, yeah, they can be even associated with cerebral edema as well. Someone may be presenting with pulmonary edema, even hypo or hyperkalemia as well, hypoglycemia as well. So that is the reason. So to arrive at a diagnosis, the key important thing is do a fingerprint test, not just for the blood sugar levels, but also for the ketones. Similarly, when you're trying to see for the venous pH or the gas as well, it should be taken from the venous blood. Unless and until, and you should all, again, same way try to do for the ABG, in fact, okay? So whenever you're trying to see for the pH or the gas as well, blood levels, you should use the venous, in fact. Unless and until you really need is a ABG. And now the emphasis on the urine ketones is much less. So as I had already said about some of those criteria for the high risk patients, low, medium, and high risk, right? So how do you differentiate the high risk patients? So as I had was already telling, ketones, if it is more than 6, high risk. Similarly for the bicarbs, less than 10, yes. The pH levels less than 7.1 or 7, in fact, or even the SpO2 is less than 92, and of course the Glasgow-Coma scale, if it is less than 15, you got to be careful. Similarly, when you're trying to think for the standard fluid orders, you should try to, as I had already said, it is you have to keep on giving normal saline over 1, 2, 3, 4, 5, 6 hours, and add 40 millimole KCl to the second and subsequent bag if the potassium is going to be less than 5.5. So as I had already said it is, we are trying to keep the potassium levels slightly on the higher side. So what about this fixed rate insulin? Why are we giving fixed rate insulin? Because mostly in the ICU setup, we are used to giving the sliding scale. But as I said it, till the time you are able to resolve the ketoacidosis, you should not. And what type of insulin you are going to use is act rapid, that too in the standard concentration. And you should not switch it off until you switch it off. Okay? And as I was telling you, so after that, you continue the basal insulin regimen in the form of Lantus, Protophane, or Levemir as well. And you may consider the cardiac basal pump function. And as I said it previously, you have to restart the usual subcutaneous dosing and then switch off the infusion. So let's try to give you an example. So this is Mr. JL, which is here, 63-year-old gentleman with diabetic type 1, diagnosed at the age of 14 years. And he never had any DKA episodes and all. No history of DKA. But he's having a known case on chemotherapy for the metastatic colorectal cancer. And he was having recent episodes of chesty cough. In fact, one associated with reduced conscious state as well. And you try to do those. So the gentleman comes to the ER, you're called up, you have a look, heart rate is pretty, he's tachycardia, SAT levels are like 90%, blood pressure is feeble, Systolic is like 80. Yeah. And then thyroxine levels are pretty good. But pH, when you do, it's 7.19. PCO2 levels are 26. Bicarbs are 39. Sodium is fine. Potassium is 5.9. Creatinine is 185. And the finger prick ketone, then you do. And it's 6. So what do you do? So what do you observe? So by seeing this clinical picture, what do you think? Please use the chat box. So, okay, I'm already getting some answers as well. Okay, let's try to break the suspense. So, what happens is the ketone levels are going to be more than 6, as we have already seen. These, if we look carefully at these investigation rate, so we can already, one of the first things which we all should always do is classify the patient into the mild, moderate, or is it severe decay, in fact. So when we look at all these things, so we can already know the patient is definitely severely unwell, so the standard protocol does not apply, okay? But protocol should not be, just put it in the garbage. In the sense, it is very important. So what happens is, as we had already said, it is there are several changes in the protocol as well for such kind of patients. In the sense, you should try to put it in a not in an inpatient but in an intensive care unit. In fact, you must monitor the patient carefully. Try to maintain a strict fluid chart, as I had already said it. Uh, in the initial hours, you should give more and more fluid. Okay, 500 to 1 liter, half to 1 liter, in fact, per hour, in fact, as well, especially in the earliest phases, definitely. And in the meantime, keep on monitoring the input output chart as well. As I had already said, some of those patients can be dehydrated even up to 3 to 6 liters. So you have to be giving them more and more fluid, especially in the earlier time. And as I already said it, initially you must monitor them regularly on a hourly basis. And once you are able to stabilize the sugar levels, so the sugar levels are going to be around like 200 at least, or 150 to 200, then every 2 hours, by the time if the ketosis also settles down, the and you are able to see the H plus gap as well. So only after that. But in the meantime, what was the important thing was two things. You must give fixed dose insulin, no sliding scale. Fixed dose insulin. And then the other thing is, so for example, even when we are trying to measure the ketone measurement, it should be done with the fingerprint, not with the urine. Okay? So these are some of those important things which has been changed in the new protocol, which should be adapted. So this is another patient as well. You can have a look on the history. So what do you think once you look at this? So this is a 30-year-old male patient, a known type 1 diabetic. He has a history of polysubstance abuse as well. And he's coming uh, with abdominal pain and when you try to do as well, when you try to see on an observation basis, it's normal, okay? But see for the ABG. On the ABG, you notice is the pH it is acidotic, in fact, like 7.28. PCO2 is 37. and the bicarbs is 17. On the electrolyte side, you notice like sodium levels are like okay, not bad, 139. Similarly, potassium is like 4, creats are like 16 in fact, and the ketones is 4. So what do you think about this? Please use the chat box. I would like you to use the chat box and answer what do you think now when you see such kind of history. See, this is the important thing being in medicine. We are always a physician. Whatever you are, a cardiologist or uh, whatever specialist you become, we are always a physician first. And then our specialty comes. So, those basic, I would say, emergency things we should not forget. Okay? And why is it important is so same thing as I had in my last session on arterial blood gas analysis. I hope you all will remember, which we had already spoken about these calculating those the gaps. In fact, the electrolyte gaps. What how to do that, how to take care of that as well. And this is a little bit slightly extension. There's a big role for such kind of things, electrolyte imbalances, even in diabetic ketoacidosis management as well. And that is the same thing what we are trying to do it over here. So what do you notice over here? Hmm? I need an answer from everyone because we spoke about it, right? So what do you think? What is happening over here? So do I have to leak the answer as well? Okay. So what happens is again, as I had already said, it is whenever such patient comes, always try to look out for the clinical signs and symptoms. In fact, and then you have to first of all, the first thing always try to do is to classify such patients. What type of severity of the DKA is it? Mild, moderate, or severe? So once you get these clinical parameters and the blood investigations and urine investigations and those electrolytes as well. So what do you notice? So you notice is the patient definitely has not severe, not moderate, but mild diabetic ketoacidosis. And when you are thinking for those high risk factors, they are not at all. Patient is normal, consciousness scale is there, Glasgow coma scale as well. It tends to does not favor that the patient is any altered mental state or something as well. So when you are trying to think, the standard protocol which we already spoke about, that will be something really nice. You can think of using for the patient for the treatment. Okay. So one of the key things I would really like you all Okay, my slides are of course going to be there, which you all can use for reading, learning, and relearning as well. So I would really like you all to go through this British Diabetes Society guidelines for the management of decay, so which came in like around 2011 in diabetic medicine. So it's really a beautiful summary of what are the things which you all should be using, and even recently as well from American Diabetic Association as well, there has been guidelines which is there. I would really like you all to go through these guidelines, and as I said it, try to learn more and more, and this is the things which is definitely going to be very much helpful as well. So this is something very important. Okay.